Sir, your voice is not audible, sir.
April,
Hi, sir.
is it audible now? Hello?
Yes, sir. Yes, sir.
So, maintaining of, see, there should be a balance in between clotting and anti-clotting process. If the clotting, suppose some event happened in your like blood vessel or capillaries, there is a blockage or some infection, so the blood releases from there, so it should be clotted immediately, and that clotting should be stopped again. That clotting process should be stopped, so that what happened, the excessive loss of blood does not take place. So this clotting should be there, and if suppose the clot has occurred in capillaries and the blood is not flowing beyond that region, or there is a the clot has occurred. If it is not the blood is not flowing through, then what happened? The blood will be accumulated over there, and the oxygenated blood will not be available for that area, or vice versa. To prevent that one, you should have to maintain hemostasis. Basically, there are so many factors, clotting factors are there, and platelets and injured tissue, all those things will be playing important role in this case. Basically, for the maintaining of hemostasis, three steps are required: vascular spasm and platelet plug formation and coagulation of blood. You must have studied coagulation of blood also, like genetics or intermediate or that levels. So we'll discuss. See, I'm not going in detail about all the factors. We'll discuss about the factors, but not their detailed mechanism. So first, vascular spasm. What do you mean by spasm? Spasm is getting a fluid over there, getting a fluid or edema kind of thing. Spasm means some fluidic nature. Vascular is blood. So whenever there is a cut or whenever there is a injury, then vasoconstriction. Vaso is blood vessels, and whatever the damaged blood vessel is there, its construction takes place in order to reduce the lumen size. Whatever the blood flow that is taking place, it should be reduced. So in order to reduce that blood flow, this vasoconstriction taking place, and then it tries to, by doing the vasoconstriction, the flow of, see, suppose there is a tunnel. If you try to reduce the size of the tunnels, the whole lumen, then what happened, the flow reduce. So the first thing is muscles. So whatever the lumen muscles are there, they will start contracting, and once they are contracting, what happens? Then this vasoconstriction takes place because of muscle contraction, and this muscle contraction induction will be given by the endothelial cells. The inner lining is called as endothelial cells. So this endothelial cells and smooth muscle cell, they releases, and platelet cells, they releases the signals for the, and even pain also. This smooth muscles plus the endothelial cells plus platelet cells and pain gives the signals to the muscles for contraction. So the muscle contraction takes place, then vasoconstriction takes place. And see, this process, as I told you, it is more effective in smaller blood vessels, because if it is a very big, the flow is very high, and the gentle muscle contraction may not help for the controlling of blood flow. But if the blood vessel is a smaller one, it will be quite enough for doing the control of blood vessels, blood flow. So next step, first step is vasoconstriction. Vasoconstriction, whenever there is a vasoconstriction over there, the fluid will appear over there, fluid will accumulate, which is called as spasm. So that will lead into light swelling in that area. Wherever there is a cut, you will see the small cut, edema or swelling in that area. Second is platelet plug formation. So here there is a positive feedback cycle. What do you mean by positive feedback cycle? Once the vasoconstriction is taking place over, I told you, endothelial cells, platelet cells, they need to give the signal. Once platelet cells are giving the signal, once that is they are giving the signal, then what happened? The signal that actually signaling is the chemical chemotoxis process, which is there in the external of platelet cells as well as endothelial cells. So once this is over, they give some outer coating has been lost from this platelet cells as well as endothelial cells. The outer chemical which is there as outer coating, that has lost. Once this is lost, then what happened? This platelet cells as well as endothelial cells, they sticks to one another, because see, whatever this chemical which is there outside, it serves as a, see, they're having the same charge, so they repel from one another. Once that is lost, once these particles, endothelial cells as well as platelet cells, as they loses their outer charge, now they will be attracted by one another. And these damaged endothelial cells now, they will be exposed to the collagen fiber. Okay, and see, this is a process again. This platelet cells stick to the collagen fiber via plasma proteins called as van Willebrand factor. Van Willebrand factor. This factor, which is there in the plasma, it binds to the fiber, and this fiber along with it, it binds to the platelet cells, and it causes swelling and becomes spiked and sticky and releases a chemical messenger. There is a ADP, causes the platelets to stick and release their content, and serotonin A2 enhances the vascular spasm and platelet aggregation. So this is how the spasm as well as platelet. See, some of the bunches of platelets have accumulated over there. So temporarily, if the blood flow is very high, like if the veins or arteries are there, then especially arteries, this plug will not do anything. If it is a small capillary, see, first phase vasoconstriction that is there, that is helpful in small capillaries. Second step, plug formation in small capillaries plus small veins. So larger veins and arteries, even the plug will not help. Next process of hemostasis is coagulation. Coagulation, once the platelet plug has been formed, okay, and here what happens here? Threads, a lot of amount of threads will be captured over there. See, in plug, the initiation of this fibrin binding over there has been taken place, but still there is no enough thread over there. The plug has been formed, and plug. See, suppose if the blood vessel is big, larger one, or if it is a capillary, if it is an artery, then the plug will be just like that. It will be taken away. Okay, so in case of coagulation process, the platelet plug will be binding with a larger amount of fibrin threads, and this leads to a jelly structure. This blood which is passing through that area will become a jelly nature, and in this process, series of reactions will be taking place, and a series of proteins or factors are involved, which are called as clotting factors, which we call as procoagulants. Clotting factors are called as procoagulants. I have circulated a brief information about clinical hematology yesterday in WhatsApp group. The terminologies of different thing, and hematology, I think 30-40 questions are there in that hematology. I expect all of you to go through, and they are very important in terms of getting the subject. And see, these procoagulants are 30 There are 13 procoagulants are there, and mostly they are the plasma proteins. And vitamin K, you know that for blood clotting, vitamin K is required, and these vitamin K is essential for synthesizing four of these procoagulants or cofactors or factors. It plays very important. Actually, vitamin K works as a cofactor, and it is required for synthesis of four coagulants. So it is very important thing. So if you see the steps are concerned, that's already whatever we discussed. So first, whatever the smooth muscles and gives the signals, so that longitudinal muscles will contract. That will lead into the narrowing of lumen, and it leads into the vascular spasm. And the second step, plug is formed over there. So whenever there is an injury over there, I told you external charges are lost, as well as ADP binds to the platelet cells, and it binds to the fibrins, and there it will be making a platelet plus platelet fibrin plus platelet endothelial cells attachment will be taking place, which will lead into the this plug formation. In the third, what happens here? Now, further, these platelets, once they binds to one another, they will release further signals, and these signals, actually factors, cofactors, factors are procoagulants. They will be helping in the blood coagulation. They will be gathering more amount of fibrin over there, and this will lead into the blood clotting process. So this was the attendance of last class, and every class will be recording this attendance and will be updating coagulation. So coagulation, basically in coagulation there are three steps. First of all, see, majority of the proteins, as we need to maintain them always ready, but they should not work. Even in the digestive enzymes also, there's a chymotrypsin is there. There's a most of the time inactive enzymes are there, and whenever they are required, they will be made active. The similar thing in case of a blood clotting also, you are inactive cofactors or inactive procoagulants. So prothrombin activator, in the first step, what happens? Prothrombin is activated in the first step. For this one, intrinsic as well as extrinsic factors or pathways will be useful. Intrinsic are in body, within the body, or extrinsic is the one which is coming from outside, the signal which is coming from outside. Intrinsic is the signal coming from the damaged side, platelet, or blood flow. Those things are intrinsic. And second step is, see, thrombin is an enzyme, and that is there in the form of inactive prothrombin, and this prothrombin is activated into thrombin in the second step. And final step, that's whatever this activated thrombin is there, it converts fibrinogen into fibrin. This see, little amount of fibrin is available in the blood in soluble nature. So this active fibrin binds with the fibrin. Actually, the quantity of fibrin is limiting factor for coagulation. The quantity of fibrin is the limiting factor. If it is there in enough quantity, then the faster the blood clotting will be taking place. So your this fibrin quantity, if you don't have enough quantity, the blood will be flowing. So this for this fibrin synthesis, your all 13 cofactors of blood clotting will be playing important role. So first step, what is the first step? It is prothrombin activation. Whatever the thrombin is there, it should be converted into thrombin. Simple. So it is initiated by intrinsic as well as extrinsic factors or pathways. So both the things are involved here. And here, this blood clot process, the first process, the conversion of prothrombin to thrombin, it is triggered by the tissue damage events. What happens whenever there is a tissue damage? What happens? Whenever there is a tissue damage, whenever there is a cell damage, intracellular content will be released. Mm. And generally, cell signaling process, most of the time, whether it is intracellular or extracellular, cyclic AMP plays very important role. Cyclic AMP actually, which is there inside the cell, that will be coming out. And this cyclic AMP gives the information to the adjacent platelet cells and epithelial cells. There is a damage has been occurred. And whenever this cyclic AMP comes over there, then many factors, clotting factors, are, we can call them as the procoagulants, they will be accumulating over there. And what happens? Each pathway cascades toward the factor 10. 10th factor will be accumulated here. Factor, there is now, this is called as 10th complex, factor 10th complex, and which is also having calcium PF3 in that one. And there is a factor 5. Here the cascade is there. I will explain. I'll go to the cascade bit before that one. We'll explain the factors, intrinsic factors and extrinsic factors. Okay, intrinsic factors are the internal factors, as I told you, and these intrinsic factors are triggered by negatively charged surface. I told you actively whenever there is a cut. After the cut, immediately the like platelet cells. Originally, the platelet cells are having negative charge, as I told you. Once they identifies that there is a cut, they will give their negative charge as a signaling. Okay, this signal works as an intrinsic factor. You know, platelet cells are the internal components, our body components, and collagen, glass, everything which is there in our body, it serves as a intrinsic factor. Okay. And these factors, as they are there inside our body, we call them as intrinsic factors. Extrinsic factors, whenever there is a triggers by exposure to the tissue factors, are factor 3, an extrinsic factor. It is not produced, it is not a blood one, it is local site, it is coming from somewhere else, and it bypasses several intrinsic factors and directly it causes the blood clotting process. Whenever there is a tissue damage, when the tissue damage is there, then the blood clotting will be taking place very fast. It will be very fast. See, suppose if the wound is not healing, if the wound is not healing over there, then there's some disturbance. They will do some destruction in that area. So the tissue factors will be released, and they will be increasing not only the blood clotting, they will also promote the cell proliferation also in that area. That will lead into the cell growth. So first step, what is the first step in that one? What we discussed, conversion of prothrombin activator, getting the prothrombin activator. Then prothrombin activator that catalyzes transformation of prothrombin to active enzyme, that is thrombin. Okay, once the prothrombin activator clot forms within the 10 to 15 seconds. This prothrombin formation is should be fast. If this process is delayed, if a person gets delayed this process, then what happens? The clotting also gets delayed. Then third step is formation of mesh. Whatever the thrombin formation is there, it converts soluble fibrinogen into fibrin. It converts soluble fibrinogen into insoluble fibrin. So the fibrin strands, whatever the strands are there, form structural basis of clot. So they will be messing. They will be like your cloth. They will be making a cloth-like structure over there, messing kind of thing. They will mess kind of structure they will be making over there. In between, whatever the platelet cells are there, RBC, WBC, they will be captured in between, so that the soil, whatever clot will be making over there. And fibrin causes plasma to become gel trap for formed elements. And here, especially thrombin with calcium activates factor 13. There's activates factor 13, and this helps in the cross-linking of fibrins, and this strengthens and stabilizes the clot. If you see into detail, I'll if you see the detailed processes, phase one, what is the phase one? Conversion of prothrombin activator, getting a prothrombin activator. How the factors are involved in this process? There are two processes are there, intrinsic as well as extrinsic. I told you, extrinsic process is a rapid and simple process. Here, just see, in the presence of calcium, seventh factor is activated to 7th A. And this here it helps tumor this tissue factor helps here in this conversion of 7 to 7A. And in the presence of 7A plus tissue factor, what happens here? This helps in the conversion of here 10th factor into 10th A factor. This is nothing but activation of 10th factor. 10th A is activated version, 10th is a normal version, pro version, and 10th A is a activated version. And again, this 10th factor converts 5th factor, inactivated 5th factor, into active 5th factor. And now this 5th factor, in the presence of, and in fact, even activated 10th and 5th factor in the presence of calcium plus PF3, it makes it activate whatever the inactive prothrombin is converted into, prothrombin activator is produced in this case. This is extrinsic factor, whereas intrinsic factor is concerned whenever there is a damage, endothelial cells ruptures, and tissue rupture will be taking place, and the platelets will be they provide the signal from their surface. In this case, what happened? The 12th factor is activated into 12th A. A is nothing but active 12. Okay, and this activated 12 factor again in turn activates factor 11. Factor 11 converts into active 11 factor. Then this 11 factor again now it activates. See here, either 11th A or there's the 7th A activated, which is coming from the factor also, and along with the calcium activates the 9th factor into 9th active factor. Okay, now this 9th factor and this even platelet factor 3, PF3 it is called as, and released by the aggregated platelets, it converts there is a 8th factor into active 8th factor. So the here 8th factor plus 9th factor which is generated here. See here, this is the 9th factor which is generated, activated, and this is the 8th factor. So 8th and 9th factors, these two factors can convert 10th into active 10th factor. But here in the similarly, even 10th factor is activated with the help of tissue factor as well as the activated 12th also. See, these factors are very important in terms of your competitive exams also. Which factor plays which role? Hemophilia. In hemophilia, which factor plays important role? Hemophilia. See, hemophilia is a genetical disorder where the blood flow is continuously taking place. Any gentleman, can you tell me which factor plays important role in which factor is a deficit in hemophilia? Satish, పడుకున్నాడు. హిమోఫిలియా చదువుకున్నారు కదరా జెనెటిక్స్ లో. Okay, sir. It is there in our presentation. Just have a look. మీరు పడుకున్నారు నాకు తెలుసు. Uh, Anybody, can you reply which factor plays important role in clotting factor? This is hemophilia. It is factor 12. Okay. Once that prothrombin activator is produced, is prothrombin 2, which is inactive in form, that will be converted into active thrombin or 2A. Actually, thrombin is considered as a factor 2. And now, this prothrombin, once it is converted into thrombin, for which what we required, prothrombin activator is required, which is produced in the phase 1. And once this thrombin is produced, it converts the fibrinogen, and it converts the soluble fibrinogen, is called as factor 1, and it converts into insoluble fibrin 1. And this insoluble fibrin are cross-linked, or they are meshed with the help of calcium. See, calcium factor 13, factor activated calcium. This is activator factor 13. So calcium is required for activation of factor 13. Okay, factor 13 makes your insoluble fibrins into mesh form, so that further blood flow from that area will not be taking place. A mesh kind of thing will be formed in that area. So this is how you can see the blood clotting takes place. This is a electronic scanning electronic microscope of a clotted area. In that area, see how the RBCs are trapped in that particular area. And platelets, where are the platelets? This small white, what these structures are there? These are the, and this is the fibrin mesh. So once the clot has been formed, then you need to do the stabilization also. See, suppose if there is a clot in what you call your blood vessel, larger big vessel, that may not be enough to stop the blood flow over there. So the subsequent proteins, actin and myosin in platelets contract within 30 to 60 minutes. Then contraction pulse of fibrin starts squeezing serum from the clot, draws this ruptured blood vessels adjust together. Then what happened? The clot size increases. The clot size increases, which will lead into stopping the flow. Then vessel repair. See, temporarily we try to reduce the blood loss over there by doing the blood clot. Simultaneously, you need to do the blood vessel repair also. Whatever the blood vessel is there, it has to repair after the blood clot process. Here, there is a platelet derived growth factor, which is called as PDGF, stimulates the division of smooth muscle cells and fibroblast cells to rebuild blood vessel cells. Here, once see damage has occurred, so surrounding cells, whatever the damaged cells adjacent to the damaged cells are there, they will divide, and even fibroblast cells also helps in this process. And once they are damaged, from both sides, once they are growing, they will be attached at one side, so that damaged area is completely healed. So vascular endothelial growth factors stimulates the endothelial cells to multiply and restore the endothelial lining also. See, these two factors, there is a platelet derived growth factor as well as vascular endothelial growth factor. These two plays very important role in case of healing. This healing has done. It is not like a single day process. Healing do takes place sometime. And fibrin, whatever the clot has been formed, that has to be removed. Once clotting has been taken place, and what you call your damaged tissue has repaired, and blood flow, whatever the blood vessel has made normal. Now, whatever the fibrin clot has been formed inside, it should be lysed. Otherwise, what happens if it is a continuously blocking thing? Then the other side oxygen will not be taking place. Blood flow will not be taking place. So generally, tissue damage, whatever repair will be in place within 2 days, 2 to 3 days, so that quickly once, like if it is a 50-60% tissue damage has been repaired, then fibrinolysis will be taking place over there. And so fibrinolysis starts from 2 to 3 days, 2 days, and it continues for several days. And for this one, plasminogen in clot is converted into plasmin by tissue plasminogen activator. Plasminogen, whatever is that TPA, tissue plasminogen activator, that is being produced a factor. What factor? 12 and thrombin plays very important role here. Plasmin is fibrin whatever the digesting enzyme here. Once the plasmin is produced, what happens here? Fibrin is cleaved off over there, and once it is cleaved, then the clot is broken down over there. గట్టు పగిలిపోతుంది. Here factors limiting clot growth and formations, like how much time it requires and how much size the clot should be there, and all those things are dependent on two processes. One is there is a diluting or removal of the clotting factors. 13 clotting are involved in this case. This 13 clotting factors. See, suppose clot number 12, sorry, factor number 12, if it is not there in sufficient quantity, then the clotting initiation of the intrinsic pathway does not take place. That if the 12 is not there, say in hemophilia, which is genetical disorder, it is not produced in quantity. That is diluted. Otherwise, suppose due to like accident, a big injury has occurred and a lot of blood has been lost. So along with the blood loss, you have lost your clotting factors also. So it has been removed. The clotting factors have been removed from the body. Then if you are doing the transfusion, not blood. So if you are doing the transfusion of like in order to maintain, generally what the doctors will do, immediately they will transfuse the cell. If you do the saline transfusion, that do the dilution of the clotting factors. The concentration of the clotting factor in blood per ml, the concentration gets reduced. This also will delay the clotting process. So the clot will not be very larger one. The clot will become, by these two processes, like loss of clotting factors from the body, and second, dilution of clotting factor by transfusion, blood transfusion. If a person, what happened if a person has lost due to accident, if he lost a lot of blood, the blood pressure goes down. In order to get his blood pressure, immediate doctors will transfuse a lot of fluid into his body. So whenever you do this transfusion, the clotting factors will be diluted over there. Then what happened? The clot size gets reduced. Second, then inhibition of inhibited clotting factors. This whatever the activated factors are there, whatever so far we discussed, and even prothrombin activator also, which is produced in the first phase. Even that also. So if those things inactivated, if inhibited, then even the clotting factor, the clot size gets reduced. Thrombin bound and fibrin gets this is also gets. Antithrombin 3 inactivates the unbound thrombin. Heparin, normal anticoagulant what we use for our regular procedures. See, whenever you require plasma to be separated, we'll add this heparin is taken in the syringes, little amount, and very little required this one. And whenever you heparin, then what happened? Blood clot does not take place, and when you do the certification, the serum will be coming, plasma will be coming in the top, and remaining cells will be there at the base. So this heparin, basically, you should know that it inhibits the thrombin by enhancing the antithrombin 3. It inhibits thrombin formation, and prothrombin is converted into thrombin, and this thrombin conversion process will be blocked by antithrombin factor 3, which is promoted by heparin. And see, something undesirable things in our blood, like a platelet addition is generally, this platelet addition is prevented by smooth endothelial cells of blood vessels. I told you, normally platelet cells as well as endothelial cells both are having negative charge over their surface. So in normal cases they cannot come one in contact with one another, because you know that negative charges will repel with. So in normal cases, this platelet cells cannot interact with the endothelial cells, or smooth endothelial cells, and what happens, and prevents the platelet from the clinging, this attachment or localizing over there. And antithrombic substances like nitric oxide, and see, nitric oxide is there in our blood. It is there in continuous form. It is there in little amount. You know, nitric oxide is a laughing gas, and it is there in small amount. Will be having this nitric oxide, and it flows along with your blood, and this maintains antithrombic activity. And see, prostacyclins are secreted by the endothelial cells, and they also helps in the antithrombin formations. And the vitamin E, quinone substance, it is acts as a potent anticoagulant, which is there. Actually, as age goes on, this vitamin K quantity gets reduced, and this irregular or abnormal clottings will be taking place over in those. That is about hemostasis. So now we'll discuss the disorders, the problems what we face due to abnormal hemostasis. First is thromboembolic disorders. Embol is like a clot which is flowing. Flowing clot is called as embol. If it is a if it is a blood one, it is called as thromboembolic disorders. And second is bleeding disorders, abnormalities that prevent normal clot formation. And disseminated intravascular coagulations, DIC, involves both type of disorders. That's the top two. Thrombus, a clot that develops and persists in unbroken blood vessel. Okay, and that is called as thrombus, a blood clot which is there in the blood vessel. And this may block the circulation, leading to the tissue death. And if this thrombus, if it is moving, if it is a freely floating, and if it is moving from in the blood vessel, it is called as embolus. It is embolus. Okay. And this embolism, there is a one more process word, embolism. Embolus, whatever the embolus, the floating blood is there, if obstructs a vessel, pulmonary or cerebral emboli, if it goes over there and blocks, so that subsequently the blood flow will not be taking place. This is called as embolism. The injury has occurred, a thrombus has occurred at some point, and it has converted into embolus, means it is free flowing, and it is going somewhere, and after going that area, it is blocking that artery or vein. It is called as embolism. It is very dangerous if it is blocking the brain. Very frequent this kind of cerebral embolism happens, and you need to do that. And risk factors like atherosclerosis and inflammation, slow flowing blood or blood sepsis from immobility. These factors plays very dangerous along with these clotting issues. Atherosclerosis, actually this is a foreign antigen. It could be streptococci, bacterial protein, or it could be some other protein. See what happen. It will causes a clot formation over there, that thrombus, and it will become a thrombolus, and that thrombolus will move and go somewhere and blocks. Will becoming embolism. It's very dangerous. Anticoagulant drugs. Aspirin is the first. All the cardiac patients who are operated, they are given this aspirin. I think in chemistry you will be practicing the preparation of aspirin also. This is a anti-prostaglandin. You know, I told you prostaglandins, prostacyclins are produced by the epithelial cells to prevent the coagulation process. And here, sorry, prostacyclins are produced for anticoagulation, and this is anticoagulation. This is also aspirin is also anticoagulant, and antiprostaglandin, this aspirin, and that inhibits the thromboxane A2. Heparin, as I told you already, it is anticoagulant used clinically for pre and post-operative cardiac care. And warfarin is a organic compound, safe compound, but it is very expensive compound, used for those who are prone of arterial fibrillation. Fibrillation is minute at arteries. You know, arteries damage. It's very difficult. You need to stitch. If suppose somebody is making suicide attempt by cutting their arteries, like it will not be healed by your whatever the contraction, spasm, and clotting process. It has to be stitched out. So the surgery, small, minute surgery, has to be done in that case. And warfarin is an efficient anticoagulant. Like at least a small arteries, till fibrillation, small cuts are there. Those things will be repaired with the help of warfarin. And it interferes with the action of vitamin K. So the major 4 clotting proteins factors are there. They will be inhibited by warfarin. And dabigatran is directly inhibits the thrombin formation, so that it is more effective. So as it goes from the up to down, efficiency will be increased. But aspirin, generally it is preferred because it is cheap, and it is not having many other side effects. And bleeding disorders, thrombocytopenia. And here in this case, here the platelet cells gets reduced. Thrombocytopenia, the platelet counts gets reduced. You know, we discussed about platelets in individual cells. What should be the number of platelet cells in individual healthy individual? 50,000 to 4.5 lakhs. So in dengue patients, gradually they gets reduced. Suppose if the number is reduced, if the disease gets established more, then you will be getting bleeding in from the gums, or wherever the small cut is there you'll be having the blood. And even the cancer also, I told you in this blood cancer, because mature type of cells are not being produced, or abnormal being produced, even platelets also gets reduced. Even this case also, abnormal cells, because of your required cells are not there, what happens here? Clotting does not take place. So bleeding, generally the bleeding will be taking place. And petachia appears due to spontaneous widespread of hemorrhage. Hemorrhage is there is a blood loss due to suppression or destruction of red bone marrow. This is happening. Actually, all the cells are being, in adults, all the cells are being produced in bone marrow itself. And this bone marrow, red bone marrow, due to malignation or cancer, radiation, drugs, this happens. And platelet counts, if it gets reduced less than 50,000 per microliter, it is considered to be the thrombocytopenia, and treated with immediately if you need to transfuse the platelet cells. Next, bleeding disorders impaired liver functions, inability to this is one of the reason of blood clotting issues. inability to synthesize procoagulants. All the factors, majority of the factors are produced by liver, and here even vitamin D, vitamin K deficiency also leads to the this factors synthesis. So if the K deficiency is there, or hepatitis is there, or cirrhosis is there, in these cases also the factors are not produced, which will be impairing the clotting process. And impaired fat absorption and liver diseases can also prevent the liver from producing bile impairing fat and vitamin K absorption. Now the most important thing, hemophilia. Several similar hereditary bleeding also are there. The three importance are there, steps are there. Hemophilia A, I told you I thought somebody will correct and answer, but I know that everybody are sleeping here. Hemophilia A is due to the factor eighth deficiency. It is factor eighth deficiency, and it is a common in 77 type of hemophilia people. Hemophilia B, it is because of the deficiency of factor 9. Hemophilia C, because of factor 11th deficiency. What happens in hemophilia? Because of this critical factors deficiency, factor 9 is important, 8 is important, and see, 8th and 9th are very important, and even 11th is also important. This important factor, if they are missing, then the clotting does not takes place. Actually, blood clotting time is 2 to 3 minutes. In a healthy person, blood should clot within 2 to 3 minutes. And if it is not clotting, beyond 5 minutes, we call it as a hemophilia. And that is, see, suppose if you have a cut at your finger or any point of your body, if you are having a cut and the blood clotting is not taking place for 5 minutes and it is continuously flowing, just imagine how much the blood you will be losing. It is not the matter of blood losing, and that is a secondary, but the hemostasis will be lost. So symptoms include prolonged bleeding, especially into joint cavities, treated with plasma transfusion and injection of missing factors. And this hepatitis and HIV risk will be increased if you are having the hemophilia, especially. Dissimulation intravenous intravascular coagulation. This is another clotting causes bleeding. Widespread clotting blocks intact blood vessels. Several bleeding occurs because of residual blood unable to clot. Occurs as a pregnancy complication in a septicemia or incompatible blood transfusion. If you are doing this, is a normal thing. Now we'll see the transfusion. Is the time now? Okay, I'll start the second segment. There is a transfusion and blood groups. As you are much aware about especially blood groups. So I'll be completing it in another half an hour. So all blood transfusion is transfer of blood from similar group person from one person to another person, or compatible blood grouping persons. Okay, if suppose when blood loss is rapid and substantial damage has occurred, in that case, whole blood is transfused. Or some cases, packed cells, plasma or WBCs removed will be transferred in some cases whenever you require transfuse to restore the oxygen carrying capacity. If suppose you require oxygen carrying capacity is reduced in such cases, packed red cells, plasma and WBCs are removed in this case. Given in some cases, platelets are given if suppose viral disease is there. Whatever. In some cases, all blood is transfused. In some cases, you will be giving only the only the components that are required to tackle the situation. And see, actually, in our syllabus, we have hemoglobin estimation that I will discuss some other time. Probably today I will finish blood groupings, blood transfusion. For the blood transfusion, you need to know the blood groups. Then we'll be doing the cross matching also. That we'll discuss later. First, we'll do the blood group. RBC, on the membrane of RBC, there are almost 30 types of glycoproteins, and these glycoproteins we call them as antigens. And anything, what happens here? Anything that comes from the foreign generates the immune response that you know, and that compound is called as antigen. And promoters, these antigens, they promote the aggregation, this gathering of RBCs at one side, and this process is called as agglutination. And these that's what these antigens which are there on the membrane of RBC, they are called as agglutinogens. They are called as agglutinogens. Here, the type of clumping is called as agglutination, and so these proteins are called as agglutinogens. Mismatch transfused blood, if you are doing, then what happens here? It will be considered as a foreign. If suppose instead of A, if I am A blood group person, if somebody is transfusing B to me, so that B antigen is foreign to me. So what happens here? The B antibodies are there in my blood, so they will be binding all the antigens which are coming from the from the B, so that B antibody plus B antigen, they will be brought at one place. So there is a clump will be formed, which is called as agglutination, and this is very dangerous. So this agglutination, if it is happened, it may be agglutinated and destroyed, and it can be fatal. It may be life-taking. Presence or absence of each antigen is used to classify the blood groups into blood cells into different groups. And you know, ABO and RH system is well-established systems, and the other groups are there. Who proposed this ABO and RH system? Who proposed this ABO grouping system? हेलो, हाँ आ गया। मैं क्लास में हूँ, बाद में करती हूँ। ओके, मेरा क्लास होने के बाद करता हूँ। So other blood groups like this ABO and RH was proposed by Landsteiner. You must be aware about him. And there's other systems, MNS and Duffy, Kell and Lewis. The other groupings are there, and these are based on the agglutinogens. And the most common is ABO system. And here in this case, you are having A, B, and O. Here we divide ABO system is based on the glycoproteins which are there on the surface of RBC cells, and simultaneously see the antibodies which are present in the soluble form in the serum or plasma, based on the presence or absence of two agglutinogens or antigens AB on the surface of RBCs. And blood may contain like anti-A, there is antibodies, or anti-B, antibodies. If A antigen is there, the antibody will be anti-B. If the B group is there, then the antibody will be anti-A. Act against the see, this is the mechanism which is prevailing to prevent the transmission of there's a non similar groups. Okay, if anti-A or anti-B form in at about age of 2 months age, adult levels by 8 to 10. What is this? Okay, this is a common. You can see this is a distribution of blood groups. If you see the distribution of blood groups among the population, its a distribution was explained. And Asians, in Asians, we got O blood group here, and followed by A, and then followed by the B. You can see here AB blood group will be having both A and B. How will differentiate this A and B blood group? See, the I told you they are the glycoproteins. Protein is common. In both the cases, the protein is common. Whereas the binding whatever the sugar moiety is there, galactose and furanose, the sugar binding on the protein, it differs in A and B. Okay, and there are some scientists in China to convert this to remove this sugar moiety from. If the sugar is removed, then the A if the A is there, converted to O. So this research is going on, and the claims they are doing with chemical as well as enzymatic process. Chemical is activated, is achieved, but the lifespan of RBC has been reduced to almost 10%. From 120 days to almost 10 days, it has been reduced. That is a limiting factor, but still the people are working in this concept. So here, if the blood group AB is there, on RBC you are having A as well as B antigens, like here it is explained, and the antibodies are nothing. There is no and here they can receive the blood from anybody, A, B. That's what they are called as universal recipient. And this is not much for us, and where how much it is distributed. That is, but if you want, you can have a and B. You know that on RBC there will be only the B antigens are there, and in case of your plasma, you will be having the anti-A antibody. Anti-A antibodies are soluble in form, and they are there in the plasma. And these people can take the blood from B and O. And A blood group, they are of A antigen is there on the surface of the membrane, RBC membrane, and in the plasma you will be having the anti-B, and they can take the blood from A and O, and to whom they can donate? They can donate to B as A can donate to A as well as AB, and O is the last group, and this last group, not last, O group, which is not having any antigen on the membrane surface, whereas both the type of antibodies are there in their plasma. And so these people can donate the blood, universal donors we call them. But see, this is a roughly figure. See here, suppose these can donate, O can donate, actually as per rule, A can donate, O can donate to A. In A, see the anti-B is there in case of your this O person, and the antigen is there in A person. So this A and this anti-A may combine to one another to give the agglutation reaction. This do happen. So for this one, we'll do the cross matching. It depends on the the concentration. If the antigen antibodies, if the antigens are very less, if the antigen titers are not enough to make the agglutation process, still that is acceptable, for which we'll do the cross matching. We'll see later. And second RH factor. RH factor is, that it is named based on the as it was discovered in rhesus monkeys first by Landstein. So we call them as a RH factor, or it is also called as 52 factor, or it is called also D factor. RH positive people are also called as D antigen. And generally, when you are doing the blood grouping kit, it is mentioned as the D, not RH. And almost 90% of the people, 90 to 95% of the people are RH positive. RH antibodies not spontaneously formed in the RH negative people. Anti-RH antibodies form in RH negative individuals when they receive RH positive blood. And RH negative mom, this is one critical case, erythroblastic fetolysis. Erythroblastic fetolysis. Suppose if a mother is RH negative and she bears baby during her first pregnancy, if she bears RH positive baby, okay, and RH positive soluble antigen, it transferred into the mother also. And there, this factor, once it goes over there, the anti-RH antibodies will be produced. So in the first pregnancy, nothing happens because I told you, if the antigen antibody titers are not enough, they are not going to do anything. So nothing is going to happen. Then first pregnancy will be normal. In the second pregnancy, if again the fetus is RH positive, if the fetus is RH negative, nothing is going to happen. Don't worry. If the fetus is RH positive again, then again from the placenta, RH factors will move into the mother's blood. There again, see the memory cells are there in mother, and now more amount of antibodies, RH antibodies are produced in mother, and those antibodies, again, antibodies are soluble. They crosses the placenta, they moves into the baby. And what happens here? This whatever the antigens are there in the baby, they will interact. They will agglutinate. This antigen antibody agglutation takes place, and once this agglutation is taking place, the RBC, because they are adjacent to the RBC, the lysis RBC takes place. Erythroblastic fetolysis, it is called as erythroblastic fetolysis. Then it leads into the death of the fetus. So the best is if you find mother negative and there's a baby immediately after the birth. That's what the doctors will do the blood grouping. If the baby is found RH positive, immediately you need to get an injection which will remove, that's secondary antibodies of RH factor. So it will nullify all the antibodies which are produced in the mother cells. And again, see, after every delivery, you need to do the same thing. Baby treated with pre-birth transfusions and exchange transfusions after birth, and Rogam serum containing anti-RH can be prevented. This is, I told you, you need to give an injection to the mother once if the baby is positive and the mother is negative. And the transfusion reactions occurs if the mismatched blood, if you are injecting donor cells, the attacked by the recipient plasma agglutinin, then agglutinate and clot smart vessels, ruptures and release the hemoglobin into the bloodstream, and results in this diminished or decreased oxygen carrying capacity, and decreases the blood flow beyond the blocked vessels, hemoglobin in kidney and tubules and renal failures. Several complications are there if the transfusion, if you are not doing properly. And the symptoms, initial symptoms are fever, chills, low blood pressure, rapid heartbeat, nausea, and vomitings. All those things will be taking place. So the treatment is concerned, prevent kidney damage should be prevented. Dialysis you need to do. fluids and diuretics to wash out the hemoglobin you should do. And transfusion type O universal donor, uh, as it is not having AB antigens over there, type AB universal recipient. And misleading, this generally this concepts, the problem is, but still they are having the antibodies and they are having the problem. Uh, Before blood, that's what before you need to do, you need to do the blood typing. And what you need to do, you need to take the blood and you need to add the antibodies to it. ABO system is concerned, you need to do, and that's you need to take 3 drops, you need to add, there's A, B and D, and where the clumping is taking place. And we'll do the experiment also of this. Actually, we don't have a practicals for this paper, uh, Hematology SEC paper, but we'll do practice. And this, in fact, immunology or somewhere will practice these experiments. That is the first. Blood grouping, you must have done, and you will be doing in immunology also. So I will not go in detail of that one. Cross matching. This is very important thing. Blood grouping. See, we call as a O as a universal donor, AB as a universal recipient. O is having both the antibodies. So if you are injecting into patient, there's a antibody of, there's a antibody of donor, they may, these two will interact to make the agglutination. If the antigen antibody are sufficient to establish that one, we'll do cross matching. Here what we'll do, we'll take the blood from the donor and recipient, little amount of blood from donor and recipient, and we'll by taking some little amount of anticoagulant, we'll separate serum and plasma. Plasma and cells, RBC cells, will separate, and we'll wash these cells, RBC cells. Both cells will be washed. So you are separating the antibodies separate, you are separating the cells separate. Okay, plasma separate and washed cells you are separate. We are doing. So these cells, whatever the from patient's cell, recipient I will call recipient's cells, you are treating with the donor's plasma. And that's donors cells will be treated with, see, vice versa. Both 4 reactions we are doing here. A is the donor, B recipient. So from A I am separating plasma and cells, and from B also I am separating plasma and cells. So A plasma versus B cells, and B plasma versus A cells. These two are mixed. Suppose O is donating, O is the donor here, and A is the acceptor, recipient. So what I will be doing? See, this O blood groups, the plasma is taken, and the RBC cells of the recipient A will be mixed together, and we will be seeing. See, the antigens are strong enough. Here the clump will be taking place, and this you are not supposed to do the transfusion. We'll do this practical also. This is called as cross matching. This is a blood grouping process. Here, one thing that you should remember, sometimes visible clot does not take place. Sometimes visible clot does not take place. It will be in between. So what you need to do, you need to add little amount of normal saline. See, ionic strength, if you are increasing, the agglutination will be enhanced. So then you can say that type of blood grouping is there. That you are aware about these things. That's what I am not doing. And restoring blood volume, death shock may result from low blood value. I told you, whenever, suppose if the accident happens, then it may lead into the death because of the loss of blood volume. So immediately, volume restoring is important. Normal saline and multiple electrolyte, a Ringer's solution will do. That mimics the plasma electrolyte, which is having the 0.89% of normality, should be injected. And plasma expanders like purified human serum albumin and dextrans, mostly dextrans, and hetastarch. These are viscous compounds, so that these are given to the patient if he lost more amount of blood. And mimic osmotic properties of albumin, more expensive and may cause significant complications also. And diagnostic blood test, hematocrat, if you, after doing the centrifugation, whatever the RBC area, that's how much percent of RBC staggered, that is called as hematology. Test for anemia, and blood glucose test for diabetes. Microscopic examination reveals variations in size and shape of RBC, indicates anemia. What kind of sickle that will be identified. Diagnostic blood test deficiency, already we discussed in the beginning. Prothrombin time and platelet count, assess the hemostasis. SMAC, there is a blood chemistry profile, liver and kidney disorders. Complete blood picture. This is actually it gives the information all about remaining things. Check how many cells are there, hematocrit is there, hemoglobin, all those things will be discussed over there. And developmental aspect, like future fetal blood cells form in fetal yolk sac and liver and spleen. Red bone marrow is a primary hemopoietic area of, by 7 months, and before 7 months, yolk sac, liver, spleen plays important role, and subsequently spleen works as a destructing area actually. And blood cells developed from the mesenchymal cells called blood islands, and the fetus forms hemoglobin F, which has a higher affinity for oxygen than hemoglobin A formed after the birth. And blood diseases of aging, chronic leukemia, that's blood cancer, anemias, loss of blood, and or loss of production, and clotting disorders, usually precipitated by disorders of heart, blood vessel disease, vessels or immune systems. This is about. Now it is open. If you have any queries in this session, you can ask. Now you please make your cameras on, so I will record the attendance. I'll stop the recording first.